Assalamualaikum.
Yeah, Waalaikumsalam.
Am I in the right room now?
Waalaikumsalam. Yes.
Yes,
Alhamdulillah. Hmm.
Dari Mas Adit sama
Miss Anita, can we start now?
Yes. Please.
Oke, ya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, ladies and gentlemen. Welcome to room 1, Nursing and Health Services. First of all, let me introduce myself as a moderator today. My name is Adisti Rose, and I'm from the Faculty of Health Science in School of Nursing. Okay, I will be the moderator for this presentation. With the first presenter will be Mrs. Maslinda Musa, right? As from the University of Malaysia Sabah, right? As the keynote speaker for this room. Okay. Without any further ado, let us start with the first presenter. For Mrs. Maslinda Musa, time and screen is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Miss Moderator, Miss Adi Sterus, and Ibu Anita. Thank you for inviting me. To all the organizer, thank you for inviting me. We are going to start. Sorry, All right. Can see my presentation, All right. Wait, I need to minimize this one. Okay. Thank you for giving me this. Sorry, wrong topic.
Yeah, I think the first topic will
Yes.
be communicable and non-communicable disease,
Yeah,
right?
true. I'm sorry.
It's okay.
Okay. The topic for today given to me is optimizing on primary health care in our developing countries, communicable and non-communicable disease control with the support of health technology. Without further ado, let's just go into the first slide. When we talk about developing countries and developed countries and developing countries, it's actually the terms used to differentiate two groups of rich country and not so rich country, basically. But that is not the whole point. The point is that when we look at the map here, Malaysia, Indonesia, Kalimantan, and so many countries here, except of course for Singapore, are falling under developing countries. Let's look at the primary healthcare. When we talk about primary healthcare, it is actually a cornerstone of healthcare system worldwide. But its significance is particularly pronounced in the developing countries, as stated by WHO 2023, where access to healthcare is often limited. And in this region, we are referring to the developing countries. Communicable and non-communicable disease pose significant health challenges. However, with the advent of health technology, there is remarkable opportunities. Sorry, slip tongue. Opportunities to optimize public health care for disease control, as stated by few of the studies that I managed to find. Now, let's look at the significance of primary health care. Basically, primary healthcare represents the first point of the contact between individual and the healthcare system, and it serves as the foundation for promoting health, preventing disease, and providing essential healthcare services. And in developing countries, where resources are constrained, primary healthcare become more and more critical. And primary healthcare also ensure equitable access to healthcare services, making it a key driver for achieving what we call as universal health coverage. Talking about universal health coverage, it is actually cover the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and also covering the palliative care. Next, let's look at the challenges faced by the developing countries. Of course, developing countries face unique challenges.
I'm sorry,
Mm.
Mrs. Malinda. I
Yeah.
think the slide is still the
Not-
first slide.
Serious?
Yeah.
Ach, ach,
How
ach.
about others? Miss Anita?
Yes.
It's not moving, ah?
Yeah, it's not
Yeah,
moving.
not moving.
Oh, yeah. Wait, because I already in the fifth slide. How do I
Right.
change, ah?
Maybe you can stop share screen first, and then restart to share screen.
Sorry, I seriously, this is how, is it now?
Okay, right.
Sorry,
Okay,
I'm truly
please
sorry.
continue.
Yeah, I think the audience have missed so many slides. All right, basically this is the first, this is the map that I'm sharing and showing. And this
Right.
is what I'm talking about, the introduction and significance of the primary health care. And now we are looking at the challenges of the countries. When we talk about the challenges in the developing countries, we face a very unique healthcare challenges. Communicable disease like malaria, tuberculosis, HIV/AIDS continue to be a burden in our healthcare system. And this has also found by Edengma et al. In 2001 in their studies. And simultaneously, non-communicable disease such as cardiovascular disease, diabetes, and cancer are on the rise due to the changing lifestyle and diets. And overburdened healthcare system with the lack of infrastructure and limited healthcare workforce exacerbate these challenges. So these are all the challenges that we are facing currently. And let's look at the role of health technology in terms of communicable disease control. I put it here just three: telemedicine and remote monitoring, vaccination program, looking at digital platform aids for the vaccination program, and also epidemiological surveillance. And we need to bear in mind, health technology play a vital roles in optimizing public health care for communicable disease control in developing countries. Let's look at one by one. First, I'm bringing you into the telemedicine and remote monitoring. When we talk about telemedicine and remote monitoring, it is actually a solution that allows health care providers to reach remote area, providing timely diagnosis and treatment. Basically, remote monitoring of the patient with the disease like tuberculosis and HIV ensure better adherence to the treatment plans. As for instance, patient like patient is tuberculosis patient, instead of keeping the patient so long in the ward just because of the medication regime, we can allow them to go back and being taken care of the primary healthcare teams. And we still can monitor remotely using the telemedicine. Next, we are looking at epidemiological surveillance. When we talk about the epidemiological surveillance, it is a digital tools which enable real-time disease surveillance, helping authorities to track and respond to the disease outbreak more effectively. This is a study done. This is study done by Ribeiro 2000 et al. 2023, where they found that mobile app and data analytics assist in contact tracing. They are talking about contact tracing, especially during the pandemic. And when we talk about vaccination program, this is another role of health technology in communicable disease control. For instance, recently when we are hit by the whole world hit by COVID-19, vaccination programs has been implemented in all the countries in the world. And in order to monitor the people have received the vaccine, for instance, for like in Malaysia, we have what we call as My Sejahtera. Every time the people is receiving the vaccine, dose one is stated there in the system. there is a digital platform aids in managing vaccination, either it's for the campaign or either ensuring efficient vaccination distribution and monitoring the coverage rate. Therefore, these countries who have the digital platform aids are able to give the reports to WHO in a very timely manner, knowing that how many people have been covered with the vaccination program. Now, let's look at the role of technology in non-communicable disease control. Just now I'm talking about communicable disease. Now I'm talking about non-communicable disease. In terms of non-communicable disease, for it, we can there is few technology that can very helpful. For instance, it's mHealth application. That is what we know as mobile health application. And we also have electric health record. This is widely used in a hospital, and healthcare information system is also widely being used. And we need to remember, health technology also offer significant benefit to prevention and managing of non-communicable disease in developing countries. Let's look at my mHealth application. This is a mobile health. It is an application that helps individuals monitor their health, track chronic condition, and receive educational information of non-communicable disease prevention and management. And mHealth serve as promising tools to improve the healthcare delivery for non-communicable disease. Reason being is that everybody have mobile phone nowadays, and with that, what happened is that the mobile phone give the alert to the person about the drinking, hydration, about how long they have been sitting, about the exercise that they need to do, about it's just like so many things, even alert about time for taking a medication. So this is what how the mobile apps is helping. And in the same time, we also have what we call as electronic health record, which facilitate better in managing of patient data, allowing healthcare provider to track non-communicable disease risk factors, yes, and monitor treatment adherence and tailor intervention. And another one is that what we have is health information system. This has been used widely and been quite some time. It is a robust health information system which enable policymaker to assess the non-communicable disease burden, plan intervention, and allocate resources effectively. All right, let's look at the challenges and consideration. While health technology hold immense promise, several challenges and consideration must be addressed. And when we talk, the first one is of course the data privacy and security. Protecting sensitive patient data is crucial to prevent breach and unauthorized access. This data privacy and security has become it has become an ongoing debate where people when there is a data leakage, there is a concern about data privacy and security. And next, we are looking at the interoperability, where it's ensure different healthcare system and device can communicate and share data seamlessly. Yes, this is another issue when we are using for instance, when let's say you are using Apple, I'm using Samsung, can that be integrate? Then can that two gadget can communicate to share the data on health? And next is regulatory compliance. This is navigating complex healthcare regulation, obtaining necessary approval for new technologies. Of course, to get it regulatory compliance, there is a lot of red tape that we have to go through to get it approved. And next is the adoption and user acceptance. Of course, user acceptance, whether we as a user ready to use the technology. Encouraging healthcare professional and patient to embrace and use new technology effectively. It's just not the patient who refuse, it can be the healthcare professional who refuse of this technology, because we have to learn new things. And next is cost and funding. Looking at developing and implementing health technology can be expensive, and securing funding can be very challenging for the developing countries. Of course, we are looking at another challenges is ethical consideration, which address ethical issue related to artificial intelligence, privacy, and decision making in healthcare. And clinical validation, where it's demonstrating the safety and effectiveness of health technology through rigorous clinical trial. And of course, limited access, where, and when we're talking about limited access, it's a challenge because it's ensuring the advanced health technologies are accessible to underserved population. So we want to use the technology, but this underserved population, the one in the remote area, they have the access. And of course, resistant to change, overcoming resistance to technology-driven change in healthcare practices. And last but not least is maintenance and update. I think everybody is aware that keeping technology up to date and functional over time, it is actually time consuming and also very costly. With that, for the conclusion, optimizing public healthcare in developing countries for communicable and non-communicable disease control through health technology is transformative strategies. It enhance access, improve the disease surveillance, and empower individuals to take charge of their health. To success, coordination efforts are required, including investment in the infrastructure, capacity building, and data security. Ultimately, the integration of health technology into public healthcare not only enhance the disease control, but also pave the way for equitable and efficient healthcare system in developing countries. It represents a significant step towards achieving global healthcare and improving well-being of the population in needs. With that, these are all my references, and thank you.
Okay, well, thank you for the wonderful presentation, Mrs. Maslinda. Okay, for the next session is question and answer. Is there any participant that would like to ask a question for Mrs. Malinda? Mrs. Maslinda, I'm sorry. If there are any question, please raise your hand and then state your name, followed by the question. Okay, well, Ms. Malinda, may I ask a question?
Yeah.
Okay, yeah. This is an interesting presentation. I have a new insight about the control of communicable disease and non-communicable disease. Okay, with the help of technology, yeah, we can control and also monitor patients' health. So my question is, has the technology you mentioned previously already collaborated with the government? Yeah, and first question, and then second question, if the patient enter the data, can the existing data integrated with the data of patient in the primary healthcare or hospital that the patient may have admitted before? Is it clear?
Yes.
Yeah.
Okay.
Thank you. That were my
Thank you for the question. For the question number one, you're talking about the government. I can refer to Malaysian government. Currently, yes, we utilize what we call as health technology, and it's been widely used, especially in the rural area. Especially in the urban area. Urban area. And now it's spread into the rural area where we try as much as possible to give internet access or some kind of access for the rural people to utilize the technology. And when we talk about mobile health, yes. So for instance, whatever data patient is collecting in the mobile, they can bring it when they can send it to the doctors when they are seeing the doctors. and it is actually we doctors in Malaysia take it as one of the data that they need to collect from the patient. And I just want to share my husband recently. He was asked to use the what they call it to check the heart, something lah. I can't remember now. But what happened is that he's just using his mobile phone and just transfer the data to the doctor. And doctor was doctor straight away asked him because there is some abnormalities found, and he went to the hospital. We have the hospital nearby, and basically the technology has been used especially in the rural area. Sorry, again in the urban area. And for your question number 2, what is that you're asking?
Yeah, the existing data has integrated with patient data in primary healthcare or hospital that the patient has already admitted before.
Okay, as for in Malaysia current situation, because it's not widely used all over Malaysia. For instance, if I admitted in one particular hospital in Peninsular Malaysia, yes, the data is there. But when I move here in Sabah, the data is not coming together with me yet. In certain area that I go, you know, like for instance, I go into the rural area here, so they cannot access. But if I fall sick in the urban area, yes, they have access because they have communication, they have connectivity. So these are actually one of the challenges that I've been mentioning happen in developing country like us, because it's not well spread yet into the entire area in the countries. Did I answer the question?
Yes, obviously. Thank you so much. Okay. Yeah, may I continue to the presenter? Okay, so for the next, there will be we will move to another presenter. Before that, I want to thank Mrs. Maslinda as invited presenter for the great presentation about technology. Yeah, about communicable and non-communicable disease control with the support of health technology. Okay, after this, we may move to the next, to the first presenter, which is Miss Yayu Dwi Octavia with the topic, the improving nurses caring behavior at Indriati Hospital Solo Baru, effectiveness of caring training. Okay, for each presenter, there will be 10 minutes for present and question. Well, Miss Yayu, the time and screen is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, esteemed attendees. I am delighted to be here to share ideas and research in this conference. Thanks to the organizing committee for this opportunity. I will be presenting my paper titled The Effect of Nurse Caring Training based on Gene Watson theory on increasing nurses' caring behavior in medical work. Introduction. Caring behavior of nurses is a fundamental element in nursing practice to provide quality health care. Aligari et al. 2022. Nurse caring behavior involves various aspects, including communication skill, empathy skill, provision of psychosocial support, and willingness to listen to patients. Watson, 2007. Caring training program, especially in the context of nurses, aim to increase understanding and encourage the application of human and empathy aspect in care practice. Caring training has a significant impact on the implementation of caring behavior and the work culture of nurses when they provide service in hospitals. Susanti et al. 2022. Next, caring nurse training is essential to healthcare management. Factors as work-related stress and dehumanization significantly impact nurses' caring attitudes, leading to a decreased caring behavior. Previous research highlighted that 52.9% of patients reported a lack of implementation of caring behavior by nurses in hospitals. Nurani et al. 2019. There is a gap between a caring nursing theory and practice. Mattenson 2022. It is important to immediately address the issue of nurse caring behavior, as this can have a direct impact on the quality of health service provided to patients. Patients who feel mistreated or disrespected by nurses may feel anxious, stressed, or even refuse medical treatment. Therefore, research on caring training is a must to ensure the improvement of better health service. Next, the purpose of the study is to evaluate the effect of nurse caring training based on Chinwitson theory on increasing nurse caring behavior. Material and methods. This study used a post-test only design with a non-equivalent control group. The study was conducted in a private hospital in Sidoarjo Regency, Indonesia from September 19 to September 22nd, 2023. Nurses who became research subjects were recruited through confidence sampling. The sample size was determined using the World Health Organization sample size determination in health studies application. With 95% confidence interval, power of test of 79%. Anticipation population proportion 1 of 0.6 and anticipated population proportion 2 of 0.2. This resulted in a sample size of 22 respondents in each group. 22 respondents from the intervention group and 22 respondents from the control group. The study included two wards, medical ward 12, which served as the treatment group, and medical wards 15 as the control group. In medical ward 12, nurses were trained based on the caring protocol development from Chinwitson karate factor theory using the simulation methods. While in medical ward 15, no additional training was conducted, but rather followed the standard service in the hospital. The CBA 24 instrument stands for Caring Behavior Inventory 24 Development by Wolf. The items in the CBA 24 are used to assess nursing caring behavior. Researchers conducted a validity test with a significant level of 0.05 and used a sample of 30 respondents with an irritable value of 0.361. The patient correlation test ratio show a range between 0.364 to 0.893. In addition, the ground alpha value obtained is 0.941. Ethical consideration. Ethical clearance was granted on September 16, 2023 by the Komisi Etik Penelitian Kesehatan of the Faculty of Medicine, University Muhammadiyah Surakarta. Our respondents were given an explanation, both verbally and in writing, regarding the purpose and importance of the study before they completed the questionnaire. If participants agree to participate, informed consent is obtained. result. The majority of participants were between 31 and 35 years old, 15%. Had a diploma educational background, 56.8%, and had 6 to 9 years of work experience, 61.4%. Nurses with 6 and 9 years of work experience show good caring behavior, accounting for 39% of the participants. The 31 until 35-year age group had the best caring behavior of nurse, covering 32% of the participants. Compared to other age groups, nurse with a professional education background of nurse showed good caring behavior as much as 23% of the participants. Will participant with diploma education showed poor caring behavior, covering 39% of the participants. The intervention group, which received caring behavior training, had a mean score of 119.18, a minimum score of 190, and a maximum score of 120. Meanwhile, the group that did not receive caring behavior training showed lower score compared to intervention group. The men with new test ratio show as significant to Thailand P 0.00, which indicates a significant difference in the caring character of nurse between the control group and the treatment group. Discussion. Age is one of the factors that affect productivity and quality of care. Nursing education at all levels should provide a more in-depth and practical understanding of quality improvement management in the healthcare system. Taylor, 2011. Nurses who have completed higher education tend to have higher perception of care behavior. After the caring training intervention approach, there was a significant increase in caring character. Most nurses from the intervention group saw good caring behavior. In the table 4, the mean plus minus standard deviation value in the intervention group was 119.18 plus minus 0.853. Well, in the control group, it was 87.15 plus minus 6.508. The results of the study are consistent with previous research by Bakar et al. 2022, which also show a significant increase in the mean of the intervention group. Affection training will have a strong link to two aspects, namely nurses' behavior and knowledge. The training will not only improve the nurses' knowledge, but will also have a positive impact on change their behavior. Effective training will help nursing understand and apply the knowledge gained in the daily practice, thus providing tangible benefits in healthcare. Nursing managers play an important role in improving knowledge through various continuous professional development programs. Seperti et al. 2019. The result of station animal statistically significant difference between the nurse caring training intervention group and the control group, with an assumed significant two-child of 0.00, which means the value is smaller than 0.05. The findings of the study are in line with the result of previous research by Judioner and Hall 2023, found statistically significant difference favoring the intervention group in the overall care-oriented nurse-patient interaction. The study is supported by a finding reported by Permana et al. 2023. There was a significant difference in nurse caring behavior between the intervention group and the control group after receiving caring efficiency training. Simulation-based training is an effective learning tool to improve human factor skill in quality healthcare team. Human factor skills are not innate and appear to be trainable in the same way as technical skill. Therefore, simulation-based training in clinical practice is critical to understanding its impact on patient care. Caring training has a positive impact on nursing practice of caring behavior and work culture when providing service on public hospital. Applying caring behavior and providing service to patients is very important for nurses. And caring-based training programs have been shown to improving nurses' caring behavior. The development of SOAS program is essential for nurses in Indonesia in an effort to improve their practice of caring behavior. Axial et al. 2023. Conclusion: the caring behavior approach is not only limited to caring theory, but also has a significant impact on the development of nurse caring character. Improving the character of caring behavior of nurses in various hospitals can be achieved by conducting training and mentoring based on Jensen's character factor approach with simulation training methods. This is done by considering the factors that influence the formation of the character of caring, so as to achieve optimal result. The result of the study can serve as a basis for consideration for further implementation and more in-depth research in the future. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the great presentation, Miss Yayu. Okay, I'm sorry since the time has run out. So this time there will be no question and answer session because each participant will only have 10 minutes for presentation. So I will move on to the next presenter. Okay, for the next presenter is Miss Maslinda Musa again. Okay, the time is 10 minutes, Miss Maslinda.
Okay.
Please, the time and screen is yours.
All right. Thank you. And it's me again. Can see my presentation, Alison?
Yes.
All right. Let me just try. Is it moving?
Yeah.
Yes,
All right.
Right.
Okay, my topic is about the relationship between level of knowledge and 5-moment and hygiene practice among healthcare assistant in Malaysia Teaching Hospital. And these are the content outline. And for the introduction, we are talking about the practice of hand hygiene or hand washing. It is a greatly reduce the possibility of pathogen and harmful germs on the hand. And hand hygiene is one of the most crucial preventive steps that can be taken to reduce the risk of infection, transmission between patient and healthcare professional. While healthcare assistant workers are part of the healthcare team, they always deal with the patient, but they did not get proper training like nurses or doctors before becoming the healthcare assistant, especially in the Malaysian healthcare system. Yeah. For the problem statements, 5 moments of hand hygiene involve 5 situations, and as Bowell et al. 2016 found that the most frequently disregarded compliance is after touching the patient's surrounding. And according to Mona Yusuf et al. In 2020, in their studies, they stated that the lack of educational programs on hand hygiene is one reason compliance are low. Whereby assistant healthcare workers are part of healthcare team in Malaysia, but they are frequently overlooked when discussing about hand hygiene. Though they always deal with the patient while performing the non-clinical duties, yet they did not get proper training like doctors or nurses before becoming as a assistant healthcare in Malaysia systems. Let's look at the, this is what I've mentioned just now. What happened is that I want to emphasize about the healthcare system workers. This group of the healthcare workers, they are in the system just to do the non-clinical tasks, but they are facing the patient on the daily basis because they work in the ward, they work in the hospital environment, they work in the clinical environment, but they are not the trained workers. All right, the objective for these studies is to assess the relationship between level of knowledge and 5-moment hand hygiene practice among health assistant healthcare in one of the teaching hospital in Malaysia. The methodology used is that for the study design, we are using a cross-sectional research which involves 154 assistant healthcare employed by one of the teaching hospital in Malaysia. And for the sample and sampling method, we are using the probability sampling using a simple random sampling where the sampling frame was the list of assistant healthcare from various hospital departments. I mean, basically various departments in the hospital, various departments and unit within the hospital. And the sample of 154 assistant healthcare were chosen from this list using random number generators, a generator or a comparable randomized technique. And the method used is that the self-administered questionnaire was given to the participant through Google Form. All of them fortunately have the mobile phone, so we give the link to their mobile phone and they can open up the Google Form. And the researcher give the participant a sufficient time, estimated between 15 to 20 minutes to complete the questionnaire. All right, the instrument used for this study is that we use the instrument that adopt and adapt from WHO publication and DAS et al. 2020 that consists of 4 sections. Part A is a question for socio-demographic data such as age, gender, education level, training, and current workplace. Means we are looking at which department or which unit they are working. And for part B is a knowledge assessment questionnaire was dichotomous with yes, no answer. Part C is examining the attitude of healthcare assistants towards hand hygiene and satisfaction with facilities. The attitude section used the Likert scale. From strongly agree, agrees, disagree, or strongly disagree. And for part D was to examine and contrast various elements of the assistant healthcare personnel, emphasizing their knowledge, attitude, and 5-moment hand hygiene practice. Okay, we managed to get the permission to use the questionnaire from Dr. Depsis. He's the corresponding author from this DASP et al. Studies that we are using. For the ethical consideration was obtained from University Malaysia, Open University Malaysia and the Hospital Ethics Committee. And assistant healthcare was to obtain in the written consent form after explaining the study objective, content, and nature. When we do for the data analysis using chi-square version SPSS version 27. For the independence, we are choosing in the chi-square because of the independence of the observation, where there is no relationship between the subject in each group, and the categorical variables are not paired in either way. So in this case, the dependent variables is 5-moment hand hygiene, and for the independent variables is level of knowledge and practice. Result shows that strong correlation between hand hygiene knowledge and practice of 5-moment hand hygiene among assistant healthcare, with 16 degrees of freedoms and significant value of significant values of 0.00 here. Sorry, there is a typing error. Using the Pearson chi-square statistic revealed a strong association between knowledge and practice. with a p-value of 0.00. This result highlight the information crucial role in how assistant healthcare professional practice hand hygiene. Once we get the data, we analyze, we found the result, there is a recommendation that we would like to give. The first is the targeted training program. The institution should consider their staff different educational background and degrees expertise before they start implementing the targeted training programs. And of course, we are also recommending the enhancing of policy. Institution and regulatory agencies should place a higher priority on practical training and take socio-demographic aspect into account when assessing knowledge levels. Next, our recommendation is continuous education. Institutions should invest in ongoing training opportunities, workshops, seminar to guarantee that the healthcare assistant maintain and improve their expertise over time. In Malaysian system, usually the continuous education is opportunities was given to the doctors and nurses, but very, very lack opportunities given to the assistant healthcare, though they are together in the healthcare system. And next is, of course, the quality improvement initiative. Institution can assess the effectiveness of their effort in promoting and sustaining proper hand hygiene practice by using the quality improvement initiative. With that, for the conclusion, maintaining stringent hand hygiene standard in healthcare environment is essential to protecting patient, staff, averting illness linked to the industry. Everyone in the healthcare industry, including assistant healthcare, must abide to 5-moment hand hygiene practice. Research could explore the effect of administrative policy, leadership style, teamwork, communication pattern, and hand cleanliness on healthcare personnel attitude and behavior. Maintaining patient safety in terms of infection control and the standard of care in general depends heavily on these 5 hand hygiene moments. With that, these are all my references, and thank you.
Okay, thank you, Mrs. Maslinda, for the great presentation. I think we still have 1 minute left for this presentation. Okay, to all the participants that want to ask a question, please raise your hand, state your name, followed by the question. Okay, since the participant wouldn't ask, then let me ask again. Ms. Maslinda, I hope you don't get boring or you
No.
don't get yeah. Okay, so I actually a little bit not confused. I am asking in my mind about the assistant healthcare itself. So is it, as you said before, that it's not a nurse or a doctor? So what is it? It is like a paramedical or
No,
something?
they are not even paramedic. They don't have any health training at all. They just
Okay.
what we call as A level lever, and they apply for the job, and the grade is very low in the hospital. They are doing the general workers jobs, basically assisting us in getting the lab result, assisting us in changing the bed making as now, and assisting us in disposing the clinical waste, all those things that this been done by them.
Okay, so maybe it's a high school student or graduate high school student can apply for this job.
Yes, high school students only. It can be higher than that, but such a waste to apply this kind of job when you are having a higher education level. But basically, these are the job opportunity given to the school leaver who looking for the jobs.
All right.
I'm
Okay.
not sure about Indonesia. Do you have this kind of group people in the healthcare system where they are there to assist only, but they are not doing any clinical work at all? For instance, they dispose. Now we have the okay. They go and get diet from the pantry to the ward. They are the one. Those are the things that they've been doing. They send for the laundry, all these things. Because in our hospital in Ministry of Health in Malaysia, we are not yet like a private hospital where everything is privatized. For instance, laundry they privatize, so laundry people will come. Food they privatize, so food people will come. No, for Ministry of Health, they are still using this what we call as healthcare assistant. This group of people are doing all these random works, general workers actually in the ward.
I see. Yeah. If Indonesia, like you said before, so when giving the diet, so it's the nutrition hot, but maybe the
this group
students.
they are not giving, they just go and collect the diet from the yes, from the pantry down there, so they bring it up so to the ward. But in the private hospital they are not using this group of people anymore. Diet is handled by one group of people from the kitchen, so they distribute, they have their own people. But in Ministry of Health, no, kitchen is very small group member. The remaining is by the ward staff coming and collecting all those things.
Yeah. I think most Indonesia have like a private hospital. They have their own people to do the job. Okay, yeah. Thank you for the discussion, Miss Linda.
Thank you
May
so
I
much.
move to the next presenter? There will be Miss Adeleta Alfianti and Miss Dian Hudiawati. Okay, Miss Ade, time is yours, and the time is 10 minutes, yeah, for presentation and question and answer.
Yes, izin presentasi ya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
My name is Adeleta Alfiante. I'm from University Muhammadiyah of Surakarta. I will present my article tag with title Relationship between Anxiety Level and Self-Care in Heart Failure Patient in Dr. Muardi Hospital. Based on data from the Global Health Data Exchange in 2020, the number of congestive heart failure cases in the world reached 64.34 million cases with 9.91 million deaths. The prevalence of congestive heart failure in Indonesia 1.5% or around 1 million people. When male in Central Java province, when comparing between 2080 and 2090, the data shows that there has been a decrease in the cumulative incident rate or the proportion of new case of congestive heart failure in Central Java from 9.82% in 2080 to 1.90% in 2090. However, this rate is greater than the prevalence rate or heart failure diagnosis by doctor in general. Heart failure describes a complex clinical syndrome in which the heart is unstable to maintain adequate cardiac output to meet the metabolic needs of the body. Heart failure has a negative impact on change on health status in a person, but psychologically and physiologically, heart failure causes change in the fulfillment on basic needs in individual and a decrease in the quality of life, which can increase the mortality rate in individuals. Heart failure can also cause change in functional status. A decrease in functional status can reduce a person's ability to implement self-care behavior. In addition, the psychological impact that occurs in individuals with heart failure is that individuals are vulnerable to expressing symptoms of stress or excessive anxiety and depression due to the health condition they experience. Symptoms of the failure and anxiety or depression can appear together, which make it difficult to patient to distinguish between the two, causing less than optimal self-care. This type of research is non-experimental quantitative research using a cross-sectional approach. The sample involved were heart failure patients who underwent treatment at the heart polyclinic of Dr. Moordi Surakarta Hospital, totaling 123 respondents with a period of 5 September until 11 October 2023. The sample was selected using purposive sampling technique with several inclusion criteria, including heart failure patients who had undergone hospital due to heart disease, NIHA classification class 1 to 3, and were able to communicate with the research with spoken or written language. While the exclusion criteria are here failure patient with neurobiological disorder, patient diagnosis with heart failure less than 1 month, and heart failure patient with dementia. Self-care measurement using the Self-Care of Heart Failure Index atau SCHFI questionnaire consists of 20 question items divided into 3 dimensions, namely self-care maintenance, self-care management, and self-care confidence. Total score range for 20 to 80 into information less, 20 until 39 sufficiently, 40 until 60, good 61 until 80. The SCHFI questionnaire that has been modified and has been declared valid and reliable and recalls research et al. 2004 on 760 respondents of heart failure patients, obtained a combat alpha coefficient of 0.76. Measurement of anxiety using a cardiac anxiety questionnaire in Indonesian. The result of the anxiety measurement score based on the total score range for 0 to 64, with mid information 0 until 20, moderate 21 until 41, high 41 until 64. Research concluded a validity test of the cardiac anxiety questionnaire, which has been translated into Indonesian on heart failure patient at Dr. Moordi Surakarta Hospital with 26 respondents. Tests with the value of R tabel at DF24 alpha 0.05 amounting to 0.388. From the validity test result, 16 questionnaires have correlated item total value greater than the tabel value, R tabel 0.388, then the question item can measure a variable validity. The result of testing the reliability of the instrument using the SPSS program obtained Cronbet alpha of 0.732. This indicated
I'm
that
sorry
the
to
anxiety.
interrupt, Miss Ade, but I think the presentation is not moving. All right. Yeah, it has moved already. Thank
Okay,
you.
next. The result of the study consists of the respondent characteristic using age, gender, education, marital status, NIHA functional classification, and disease duration. Tabel 1. Based on this tabel, it can be seen that out of 123 respondents, most of them were aged more than 60 years, namely 51 respondents, 41.5%, and the lowest number of respondents aged 60 until 44 years, as many as 35 respondents, 28.5%. The gender of the majority is female, totaling 68 people, 55.3%, and 55 men respondent, 44.7%. Most respondents had a secondary education level of 45 people, 36.6%, and the lowest respondent with a bachelor education were 30 respondents, 10.6%. The majority of respondents had suppose totaling 110 people, 88%, and respondents with single status were 13 respondents. The severity of the disease based on NIHA functional classification 1 until 3, it is NIHA 2, a total of 67 people, 53.6%, and respondent with the lowest number of NIHA 3 as many as 31 respondent, 24.8 with disease duration less than 5 less yes, years, a total of 103 people. And disease duration more than 5 years as many as 20 respondents, 16%. Table 2 shown that out of 123 respondents, the lower self-care score was 13 and the highest was 79 and the average score was 64.93. This shows that the average patient self-care is good. In the anxiety variable, the lower score was 20 and the highest was 50 with an average of 33.11. This indicated that the average patient has moderate anxiety. The result of the data normality tests are shown in table 4. A p-value less than 0.05 on both variable. Both self-care and anxiety shown the bivariate test but analysis with the Spearman rank test. Judging from the characteristics of the respondent, the majority of respondents were at age more than 60 years, entering the advanced age category. All age experienced several specific changes in the structure and function of the heart associated with cardiac aging. According to previous research, all age in their lives tends to get closer to the creator, so that physically and mentally patients can accept about this disease they suffer. In addition, the increased age of a person also increases the level of maturity, so that a person is able to think rationally about the benefit received the doing self-care. Ningrum et al. 2090. As for gender, most of the respondents were female. The results of this study are in accordance with the theory which states that heart failure disease is suffered more by women because women experience the menopause process, at which the tree is an increase in cholesterol due to a decrease in the hormone estrogen. Jamaluddin et al. 2080. At the education level, most respondents have an upper secondary education level. Good education certainly results in positive behavior, so that it is more open and objective in receiving information, especially in self-care action. Hudiawati et al. 2020. Most respondents suffered from heart failure disease less than 5 years. The longer heart failure patients in self-care management have a fairly good experience where patients have a better understanding of the importance of self-care behavior. Patients with years of disease can accept their disease and treatment and will have good adaptation by integrating lifestyle in daily life. Ningrum et al. 2090. In this study, it was also found that respondents has good self-care scores. That is in accordance with previous research which say that a person's ability to do self-care in influenced by age, gender, education level, employed level, lack of illness, and health worker communication. Ningrum et al. 2080. Based on the Spearman non-parametric correlation test, it is found that the level of anxiety has a significant effect on self-care in heart failure patients with moderate correlation, strength, and negative direction. Namely, the lower the level of anxiety, the better the self-care
Miss Ade,
performance.
I'm sorry. Time remaining is less than 1 minute, so maybe you can just jump into conclusion. Thank you.
Okay, the study of anxiety level correlated significant with self-care variable in heart failure patient in the heart clinic Dr. Muardi Hospital Surakarta with a negative correlated, namely the lower the level of anxiety, the better the self-care performance per heart failure patient. According to OREM, humans have the ability to care for themselves. Self-care nurse by focus on the impact of this ability. Thank you.
Okay, thank you for the great presentation, Miss Ade. Okay, is Miss Purwani, right? Would like to ask a question.
Yes, okay. Thank you very much. Very good presentation, maybe. Introduce myself. My name is Purwani. I'm working ICU, PKU ICU Hospital in Boyolali, and now I'm continuing my study in the Magister of Hospital Administration and Faculty of Medicine in UMS. Yes, I think not question, but I see the table one that frequency distribution of respondent characteristic. I think this is still used bahasa Indonesia maybe ya. And now as an international conference, maybe it will be better the next time if I think all of the material use English maybe. I think enough. Thank you.
Okay, thank you, Miss Purwani. Okay, Miss Ade, that is maybe suggestion from Miss Purwani about the presentation about the data that you show to us. Okay, yeah. For the next presenter, there will be Miss Clarice Duasin, right? With the topic job stress from nurses working condition in Sabah Women and Hospital. Okay, Miss Clarice Duasin, the time and screen is yours.
Okay, start sharing.
I'm sorry, the sound is not clear.
Hello, good evening, everyone. Is it my voice clear?
Okay, yeah, the sound clear.
Yes,
It's clear.
clear.
Hello.
Okay. Yeah, hello. The slide is, you can see my slide?
Yes, we can see a slide clearly.
Okay. Can I start?
Yes, please.
Yes, okay. Good evening and selamat petang to everyone. Thank you for the beautiful moderator for the inviting for this conference today. My name is Clarice Wasin from UMS. Today I will present my topic regarding job stress from nurses working condition in Sabah Women and Child's Hospital. So this is my introduction. Nursing is a stressful profession with long working hours, ethical dilemmas, and pressure of having responsibility for patient life support care. Stress causes behavioral, professional, social, and economic impact on person under stress for a long time. When a worker needs resources or capability are not met by the demands of the job, it can lead to detrimental physical and emotional reaction that are known as job stress. According to Ichwb et al. 2017 and Daggett et al. 2016, related work causes of stress include job requirement, job roles, work overload, work underload, organizational change, and other stressors. And the issue is, according to Muktam et al. 2023, there is stressful work overload, burnout, early retirement, and transfer out encourage nurses to leave their job was reported, especially during pandemic COVID-19. This is supported by Zalihan 2023 Ministry of Health Malaysia and TEDOS 2023 WHO state stress among health workers increased during pandemic COVID-19. And the problem statement is burnout, a common psychological consequences of stress, is a prominent negative effect of stress, regardless of the working condition, particularly in caring careers. This is from Brett and Austin 2002. For example, a job with a heavy workload and demanding work standard typically result in burnout. Individual success will typically be impacted by burnout. Low individual achievement among employees will make it difficult for them to deal with challenges or difficulties. Burnout risk will rise due to the demanding nature of the work and heavy workload. Stress can be so dangerous for workers that it can endanger their lives. According to Rice, Sutherland, and Cooper, 2000, stress, although numerous articles have demonstrated that stress can also have a positive impact of work. The negative effect of stress are simple to identify. And for the objective of this study is identify the relationship between age and working condition toward job stress. And this is the literature review. And all studies agree that job stress is evidence among population, stress, and increasingly public problems. Whereas most employee in their working condition, there are internal causes, individual personality, and external causes, work-related stress. Okay. The methodology. The proposed study was quantitative, descriptive, cross-sectional research, and questionnaire become the instrument. The questionnaire is divided into two parts. Section 1 is the demographic section was age, and section 2 is the identification of the ISMA scale, which consists of yes or no. And data collection. The data collection will employ the use of structured questionnaire, which respondent will check and give answer to some question to socially data from respondents through Google Forms within 1 week. And primary data will be collected and used in the analysis using SPSS version. And the progressive sampling was used about 60 respondents with target population is nurses in Sabah Women and Child Hospital who met the inclusion criteria, and nurses category include all nurses level. And this is the result in the finding. Out of demographic, the 60 respondents, 4 out of 60, equivalent to 6.7, were 19 to 21 years old, and 42 out of 60 respondents were 22 to 25 years old, and 14 out of 60 respondents, equivalent to 23.3%, were more than 26 years old. This analysis was used to identify the relationship between age and work condition toward job stress. The analysis with Freeman wrong, specifically for the age and working condition demographic shown, there is no significant difference between job stress and age, where correlation is 0.88 and p-value is more than 0.05. The study revealed that the nurses are having stress, but overall the level of stress is low. Although there is no significant, however, to ensure holistic care given to patients, the stress and burnout among nurses should not be taken for granted. And for the discussion, the younger respondent had more tolerance on work-related stress and compared with the older nurses. And that is why most of the older respondents agree that they have experienced work-related stress. The respondents who are older, more than 26 years old, and have been more experienced on work-related stress. and the nurses who are in the younger age group may have less experience and coping skills and therefore appear to be more vulnerable to stress in the workplace. There exists a great variation in how people get affected by work-related stress, and this also depends on how long they have been subjected to the source of stress and the amount or level of the stress itself. And for the recommendation, the widespread belief that pressure is essential for an organization to fulfill its purpose had a significant impact on a great number of lives. It is advised that all organizations prepare for the unavoidable challenge and instead or use it to lessen the vulnerability of working health. Also, research should be done to determine the root cause of stress at work. It is true we all need some amount of pressure in all that we do to be able to appreciate our work and even derive satisfaction from it. Again, life's steward is full of struggles and ups and downs, frustration, and endless demands. For almost everybody, stress is the order of the day and inventable aspect in our lives. As it has been widely believed that stress is harmful, some are the opinion that is not always bad. It acts as a catalyst for people to perform more productivity, cope with pressuring situation, and pull out the best from them. Thank you. And this is some of reference. Any question?
Okay, thank you for the great presentation, Ms. Clarice Duasim. Since the time is left, I think 2 minutes left before the next presenter. So any participant that would like to ask a question, please raise your hand.
Kopi bisa share itu.
Yeah,
Kadang-kadang.
there's Miss Sri Hayu. Okay, please state the name and followed by your question.
Yes, thank you very much, Ms. Agusti Rose. I think it's a quite good presentation from Claricia. This you identify the correlation about the job stress and the age, and your results are so that there is no significant difference between these two variables. Okay, that's interesting because I think it's quite same in Indonesia that nurses also have a stress because of the burden or others. So what cause in your country the nurse become stressed? Thank you.
Apa tadi yang menyebabkan dia stres? Thank you for the question.
Thank you for the question. Thank you for the question. From Sri Rohayu, is it?
Yes, it's right.
What is the question again?
Cannot what the cause?
It's not clear.
Yes. Okay, you can hear me, Clarice, Miss Clarice. Can
Yes.
you hear me? Yes. Okay. I will repeat again my question. What is the cause of job stress in your country? Yeah, job stress in nurses. Because it means that your results showing that even young age or elder or maybe is junior or senior, I think it's quite same. They also have stress. So this my concern. What cause the nurses stress? Yeah, thank you. Is it clear?
The sound is cracking.
Cracky.
Okay, maybe I can help.
Okay.
Can
Yeah,
you-
thank you, Miss Aditi.
Yeah, so Miss Sri Rahayu is asking about source of stress from the nurses. Is it right, Mrs. Sri Rahayu?
Sounds puncak, puncak. Okay.
Yes, that's right.
Yeah.
I think the sound is not clear.
So
Thank you,
what
Miss Adisti,
make
for
the
helping.
nurses stress?
What maybe this is okay.
Okay, what is the nurses stress?
Yeah.
According to this study, I have
Real.
revealed that according to the age, actually I have the demographic has three, but today I only take for the age. And the most causes is the length of service, the length of service, and um, the working environments itself. Is it clear?
Too long service and the working environments.
Yes, the too long service and the working environment
Stress.
make them stress. Is it clear?
Yes, Miss Clarice. So you identified three variables, yeah, that cause of job stress of nurses. First is age, second length of services, and the last is working environment, right? And you
Yes.
saw in your presentation that only saw about the age and job stress.
Yes.
Okay, I think it's enough.
Today,
Yeah.
yes. Okay, thank you.
You're welcome. Okay, thank you, Ayu, for the question, and thank you, Miss Clarice, for the answer. Okay, maybe move to another presenter, to the next presenter, that'll be Miss Dian Hudiawati, Miss Della Mardiana Wibowo, Miss Eki Puspita Sonia, and Miss Afidatul Mujanida. Okay, who's the one that will present for the topic spiritual well-being related to the quality of life of health meditation?
Hi, Miss. But sorry, I
Okay.
cannot share screen.
Maybe you can send to me or send to the chat room, and I will help you to share screen.
Okay, Miss.
Okay.
Sorry, Miss. I can share screen.
Yeah, okay.
Yeah.
Miss Afidatul Mujanida, the time for presentation is 10 minutes. Yeah. Okay,
Yes.
please. Time and screen is yours.
Thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. My name is Afidatul Mujanida, one of the research member who will present our research under the title Spiritual Well-being Related to the Quality of Life of Heart Failure Patient. And the introduction. Heart failure is a clinical syndrome caused by structural and/or functional abnormalities of the heart, causing a decrease in cardiac output
or an increase in intracardiac pressure at rest or during activity. A person with heart failure experiences anxiety about change in their body. Patients with heart failure experience needing nurses' help with their physical, psychological, and spiritual problems. Spiritual well-being and its component play an important role in a person's declining quality of life. The previous literature states the spiritual well-being in people with heart failure differs from those with other chronic illness. One of difference could be caused by the prognosis of heart failure. Individuals with heart failure often exhibit high level of depression associated with an increased risk of death and other outcomes that need to be considered. The study aimed to determine the relationship between spiritual well-being and the quality of life of heart failure patients. And the method, the type of research was quantitative descriptive research using an analytical observation design with a cross-section approach. The research was conducted at the Regional Hospital Dr. Muardi Surakarta in February 2023. The sampling technique used was accidental sampling of 100 respondents. The sample criteria that have been determined include heart failure patient more than 18 years old, diagnosis of heart failure for more than 1 year, NIHA functional class 1 until 3, and willing to be a respondent. The data use primary data obtained directly from the respondent, talk questionnaire, including spiritual needs questionnaire and Minnesota living with heart failure questionnaire. Univariate analysis describes the respondent's gender, age, level of education, length of illness, degree of NIHA, marital status, and presence or absence of comorbidities. Bivariate analysis using the chi-square correlation test. And the result of the correlation test show that the expression of spiritual needs show no difference based on gender, age, educational level, employment status, and marital status. Likewise, it can be seen that the length of illness has no relevance to the respondent's spiritual needs. However, the result of the analysis carried out shown that NIHA functional status and function influence the spiritual needs of heart failure patients. The result of this study illustrates that there is no relationship between quality of life score and all aspects of the spiritual needs of heart failure patients. The patient's spiritual needs were unrelated to the general quality of life. However, they had a significant relationship with the psychological dimension of quality of life. It is action fraction and NIHA functional status. At the discussion, the high spiritual needs identified in the current research are religious needs, especially in the needs to worship. In the case, it can be interpreted as the need to pray 5 times daily because praying 5 times a day helps patients to follow the basic principle of Islam and make you closer to the God. Religiosity is tied to Muslim life and guides how to live healthy and suffering from an illness. Religiosity is a source of strength for patients facing and dealing with their illness. Apart from praying 5 times daily, a Muslim has a regular prayer habit where prayers are recited several times daily. Prayer is considered a cognitive and behavior strategy to overcome illness by seeking peace. The terminal and vulnerable nature of heart failure positively influence a person's spiritual well-being and coping strategies. The spiritual well-being of individuals with heart failure tends to follow fluctuation in physical symptoms and is influenced by disease prognosis and the uncertain cyclical pattern of acute decline. The disease factor, including NIHA functional status and other physical symptoms, influence the quality of heart failure patient. It shows that with spiritual intervention and counseling and meeting the patient's spiritual needs, their physical and psychological well-being can improve and ultimately improve their quality of life. The conclusion, the result of this study indicate that the patient's spiritual needs are not related to the general quality of life score, but have a significant relationship with the psychological dimension of quality of life. It is ejection fraction and have functional status. Individual with heart failure experience isolation and a more profound sense of hopelessness than other chronic illness. It affects the quality of quantity and spiritual process, thereby disrupting the quality of life of individuals with heart failure. Suggestions for future research and the repetition of the research is made with different research design. And thank you. Time and screen. I return to the moderator.
Okay, thank you for the wonderful presentation, Ms. Fidatul. Okay, we still have 4 minutes left for this presentation.
Yes, yes.
Okay, yeah, for any participant that would like to ask a question, please raise your hand, mention your name, and followed by the question. Yeah, Mrs. Sri Rahayu.
Yes, thank you very much, Miss Adisti. Mbak Mujanidah ya? Oh sorry, I said Mbak.
Afida,
Yes,
Miss.
Nida.
Yeah,
I
Afida.
can call you Nida. Okay. Great presentation, Mbak Nida, Miss Nida. I think it's quite interesting. A wonderful topic, yeah. I think this
Yes.
spiritual well-being related to quality of life of heart failures. I can see that you use the questionnaire of Minnesota Living with Heart Failure questionnaire. As I know that many questionnaire, yeah, used in heart failure patients, like heart related quality of life, and I think this why your team research, yeah, choose this questionnaire to identify the quality of life of heart failure patients. Okay, that's my questions. Thank you.
Yes. May I answer, Miss Moderator?
Yes, please. Okay.
Yes. Thank you for the question, Miss Sri Rahayu. And here why I am team using mini living with heart failure questionnaire. But here we modify this is MLHFQ have 20 question and then include to domain. To domain is it is physical and psychological. Like that means this adaptation. We are adaptation, but not original, but we adaptation.
So you choose the Minnesota Living with Heart Failure. Actually, in the original questionnaire, have 20 questions. Yes.
Yes.
Have 20 questions, and you make an adoption. Did you inform to the author about this? Because I think it's not easy. You have a permission from the who want develop the questionnaire. Did you inform to them?
Maybe yes.
Maybe
Yes,
yes.
miss.
You're not sure.
But this questionnaire, we uh, we test for validity and
Yes, I understood.
reliability. Yes.
Yes, yes, yes. I understood. But as long as I know that it's not just a simple way to take the questionnaire and then adoption as we want. we should inform to the developer, or I think author, yeah. I don't know how to call it. I think we need to inform to the author who developed the questionnaire, and then after we get the permissions, it's like maybe just like adoption to our cultural right, and
Yes,
also
yes.
have translation language by WHO. So you also have to follow this guidance to adopt the questionnaire. It's just not a simple way. If not, if you publish your work and the author of developed questionnaire will maybe ask you, or maybe request to you why you adopt my questionnaire, and it's dangerous if your paper will be down from the website. So this is a danger because we know the copyright of the questionnaire. Yeah,
Oh,
I
yes, yes.
think yeah we should make attention for this. Yeah, it's not easy because yeah, every author or every researchers have their own work that we should appreciate their work on the copyright of the questionnaire. Thank you.
Oh, yes.
Yeah,
Thank you,
sorry.
Miss,
Yeah,
for the attention.
yeah. Thank
Okay.
you, Miss Adisti. I return the time to
Yeah.
you.
Okay. Yeah, thank you, Miss Sri Rahayu, for the question, and also suggestion for Miss Nida. Okay, maybe Miss Nida can apply as Miss Sri Rahayu suggests. Okay, yeah, harm discussion, yeah. And then, oh, I'm sorry, warm discussion. And we will move to the next presenter. There will be Miss Eliza Rahmawati with the topic relationship between knowledge and dietary habit with the incidence of hypertension in Kartasura's primary health care. Okay, for Miss Eliza, the time and screen is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
I'm Eliza Rahmawati from Muhammadiyah University of Surakarta. Will present the research result with the title The Relationship Between Knowledge and Diet on the Incidence of Hypertension at the Kartasura Community Health Center. Introduction. Hypertension is the main factor causing cardiovascular disease and is one of the main health problems to touch the world. According to the World Health Organization, around 26.4% of the world's population has high blood pressure. Judging from the Central Java Health Profile data, it shows that hypertension still occupies the largest proportion of all NCDs, namely 57.10%. Ini nggak bisa. Introduction. Hypertension can be caused by hereditary factor, gender, age, diet, lack of activity, and stress. In modern times, what the majority of people in the world often do is consume fast food that is high in sodium. In general, the elderly are an age that is vulnerable to the risk of hypertension. However, due to several factors, young adults and pre-elderly people are also aged that can be at risk of developing hypertension. This is evidence that there has been a shift in the population of hypertension sufferers from the elderly to the younger in Indonesia, the cause of which is not yet known. Research purpose. From the background, if this research, the aim is to find out whether there is a relationship between knowledge and diet on the incidence of hypertension in young adult to pre-elderly ages 30 to 54 years in people living in the Kartasura Health Center area so that preventive measure can be taken. Methods, research place and time. The research was conducted in the Kartasura Health Center work area in the time period September to October 2023. Research design. This type of research is quantitative research using descriptive survey analysis methods. Sample. The sample was selected using a quota sampling technique of 105 people and 91 respondents were obtained calculated using the sloping formula. Population. The population in this study were people who lived and had visited the Kartasura Community Health Center, aged 30 to 54 years and without comorbid. Data analysis. Univariate and bivariate analysis ring Spearman. Research instrument. The instrument used in this research to measure the level of knowledge uses a questionnaire adopted from previous research Homsan 2021. The questionnaire consists of 15 questions regarding knowledge about hypertension. The dietary pattern measure questionnaire in this study used the food frequency questionnaire Rahayu 2021. The question contains 10 items that describe eating patterns in the last 1 month. Based on the table above, it can be concluded that of the 91 respondents, the majority were aged 46 to 50, 31 people. Characteristic of respondent based on gender, the majority were women, 59 people. The characteristic of respondent based on their highest level of education were 35 respondents with a final education of high school. The characteristic of respondent based on work with the highest frequency were workers, namely 34 people. Results Table 1 and 2. From the result of the Spearman rank correlation test, it showed that the significance level of the test is less than the critical limit of 0.05, so that the test decision is HO is rejected, and it can be concluded that there is a relationship between knowledge and diet and blood pressure in people living in the working area of the Kartasura Health Center. From the research sample of 91 people, there were 48 people who had insufficient knowledge, and almost all of them, namely 42 people, had blood pressure above the normal limits, either in the category of grade 1 hypertension or grade 2 hypertension. There were 64 people had poor eating patterns and 48 of them had blood pressure above the normal limit. Conclusion: based on the research result, respondents with the majority of knowledge and good eating patterns had normal blood pressure. So it can be concluded that there is a relationship between knowledge and eating patterns and the incidence of hypertension in the community in the Kartasura Community Health Center area. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you for a great presentation, Miss Aliza. We still have 2 minutes left. If there are any any question, please raise your hand. Okay, I think there are no questions.
Assalamualaikum.
Oh, Waalaikumsalam.
May I give one? I have one question actually. Is it possible or not?
Yeah, please. We have
All
1 minute
right.
left.
Okay.
Okay.
Johari here from UMS Kota Kinabalu. I'm interested with the title of relationship between what is it, hypertension, isn't it, with diet. Okay, that's a good idea. But I just want to inquiry why you start from 30 years old, because we have a young hypertension. Actually, we worried about young hypertension rather than more than 30 years old. But maybe you have some great reason that your respondent is start from 30 years old. Is it, do you have any ideas why you start from 30 years old? Thank you.
Okay, Miss Eliza, you can answer the question.
Maaf Bu, boleh dibantu translate kan?
Okay, it's okay. No problem. I just translate for you because I'm expert in Indonesian. Okay. So, kenapa saya lihat respondennya adalah daripada 30 tahun. Dia start with 30 years old. Bermula daripada 30 tahun. Actually, in our the new studies show that the young hypertension grow, right? Prevalence among young hypertension ataupun kadar berlakunya penyakit darah tinggi, hypertension dalam kalangan umur di bawah 30 tahun tu meningkat. That is most dangerous, alright, compare then yang 30 tahun ke atas. Okay, jadi soalannya adalah kenapa responden bermula daripada 30 tahun diambil. Then exactly betul-betul sehingga 53 tahun. Why you very ridiculous? Kenapa you betul-betul meletakkan umur 30 hingga 53 tahun? So 55 years cannot be because it's the exclusion criteria. Your inclusion criteria in terms of age starting from 30 years old until 53 years old. So maybe you have a answer. Okay, thank you.
Is that clear, Eliza?
Ya, Bu izin menjawab. Saya memilih responden yang berumur dari 30 tahun sampai dengan 54 tahun dikarenakan sekarang tuh kan banyak sekali faktor-faktor penyebab hipertensi. Di antaranya itu gaya hidup. Sekarang pada zaman modern sekarang eh, masyarakat cenderung mengkonsumsi makanan yang eh, cepat saji. Makanan cepat saji itu sendiri eh, banyak mengandung eh, sodium seperti itu. Makanya saya memilih responden yang berumur 30 tahun sampai 54 tahun eh, yang dewasa dewasa menjelang menjelang lansia seperti itu.
Okay, for Dr. GDM, I'm sorry, whom I speaking to? Dr. GDM. Okay. Yeah, thank you for the answer, Eliza. We may move to another, the next presenter.
Thank you.
Okay. Dr. Jari. Okay. Is it clear for you? I'm sorry.
Yes, clear. Yes, thank you.
Okay. Yeah. Thank you. We may move to another presenter since we are running out of time. The next presenter will be Mr. Muhammad Najib with the topic the effect of chest physiotherapy on oxygen saturation and respiratory rate in pediatric pneumonia. For Mr. Muhammad Najib, time and screen is
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Introduce myself. My name is Muhammad Najib. I'm from Muhammadiyah University Surakarta. I here will present the result of the journal entitled "The Effect of Chest Physiotherapy on oxygen saturation and respiratory rate in pediatric pneumonia." Well, we start from the first one, which is the detail for the next year. There are several parts, starting from introduction to next method, next result, next discussion, and end conclusion. For the first one is introduction. Every child is precious to his or her mother. There are many terrible diseases that can threaten the life of children. One of them is respiratory disease, which is one of the leading cause of death in children under 5 years old. Children with respiratory problems often have excess moisture in their lungs, often build up and become thin, making it difficult to expel. The most common respiratory diseases suffered by children include acute respiratory infection or ARI, pneumonia, asthma, and tuberculosis. Pneumonia is an acute disease of the lower respiratory tract that affect the lung perism, including the alveoli and interstitial tissue, resulting in tissue inflammation on one or both sides of the lung. Mass pneumonia is caused by virus or bacteria. In general, the bacteria that play the most role in the occurrence of pneumonia are Streptococcus pneumoniae, Haemophilus influenza, and Staphylococcus aureus, as well as the atypical bacteria Chlamydia and Mycoplasma. Mani 2018. Based on 2019 data, pneumonia and diarrhea are still major problems, causing 979 deaths pneumonia and 746 deaths diarrhea. The increase in the number of deaths in the neonatal period reflect the decrease in mortality of children aged 1 to 59 months compared to newborn. One of the efforts made to control this disease is to increase the discovery of pneumonia in children under 5. The discovery of pneumonia in children aged 1 to 59 months is usually a characterized by respiratory distress. Respiratory distress is the body is compensating for an oxygen imbalance. Low oxygen concentration stimulates the central nervous system and increase the frequency of rapid breathing. If this effort is not compensated, it can affect oxygenation status ranging from mild to severe and lead to an emergency. Mulyasari and Indrawati 2018. The World Health Organization 2019 suggests that the diagnosis of pneumonia is based on the presence of chest aspiration or shortness of breath in children with cold, and or short of breath, and the presence of severe pneumonia in quiet children, which is a sign of general distress or stridor. Pneumonia is responsible for 14% of death in children under 5 years old, accounting for 740.180 death. Pneumonia is a worldwide health problem due to its high mortality rate. Pneumonia has claimed the life of more than 80.080 children under 5 years of age worldwide, or 39 children every second. Globally, more than 801 and 1.000 children under the age of 5 from pneumonia. In countries such as Nigeria and India, half of the children under the age of 5 from pneumonia. The incidence of pneumonia in developing countries is 10 times that of developed countries, and the number of pneumonia-related death is 2.000 times that in developed countries. Asia, particularly the Philippines, ranked fourth in the number of pneumonia cases in 2013. In another
I'm
Asian
sorry,
country,
Mr.
Malaysia,
Muhammad
pneumonia
Najib.
mortality.
The time
Yes.
left is 1 minute, so you may jump into discussion and then conclusion. Thank you.
Conclusion. The result of the case study showed that the child with pneumonia was able to resolve dyspnea and clear their airway with 15 minutes of CPA technique or chest physiotherapy treatment. Oxygen saturation increased and respiratory rate decreased as a result of the treatment with return, but to normal level. Chest physiotherapy can be recommended in pneumonia patients with inadequate carrier and dyspnea. For best result, this procedure should be performed before the patient eats and before bedtime and should also be performed by experienced nurse staff or medical personnel in a clean and healthy environment. Thank you. I return it to the moderator. Thank you.
Okay, thank you, Mr. Muhammad Najib for the presentation. Okay, I am so sorry because we are running out of time, so I will move to the next presenter. There will be Miss Septi Runisa with the topic the correlation between sleep quality and self-care in patients with heart failure. For Miss Septi, the presentation time will be 10 minutes. And the time and screen is yours, Miss Septi.
Belum. Okay, thank you for the moderator. Kurang besar. Assalamualaikum warahmatullahi wabarakatuh. First slide there. Okay, let me introduce myself. My name is Septi Khayonisa, undergraduate student of Nursing University Muhammadiyah of Surakarta. Today, I'll present my research result with the title The Correlation Between Sleep Quality and Self-Care in Heart Failure Patient. Next slide. Okay. For introduction, heart failure is a complex clinical syndrome problem caused by functional and structural damage to the heart characterized by inadequate performance of the myocardium, resulting in disruption of blood supply throughout the body. And heart failure is a complex disease characterized by symptoms that are short of breath, like swelling, fatigue, and can be accompanied by signs of increased jugular venous pressure, pneumonia, and peripheral edema. And the prevalence of heart failure based on the global data holds in 2020, the number of cognitive heart failure causes in the world reached 64.35 million causes with 9.91 million deaths and estimates 3,046.70 billion US dollars spent on patient care costs. And in Indonesia, cardiovascular disease is a disease with a high prevalence of morbidity and mortality, which is about a quarter deaths caused by cardiovascular disease. And the prevalence of heart failure in Indonesia, based on basic health research data in 2018, it's around 1.5 or 1 million people. And the prevalence of heart failure in Central Java province, when comparing between 2018 and 2019, data show that there has been a decrease in the cumulative incidence rate of the proportion of new cases of cognitive heart failure in Central Java from the previous 9.82% in 2018 and to 1.90% in 2019. But based on the result of the data report from the American and sleep quality, the most common sleep breathing problems are central sleep. Belum Jar. The most sorry, ma'am, the signal is unstable.
Okay, maybe you can send it to the chat room so that I can help you. Oh, it's already.
Okay, the sleep quality heart failure patient, the most common sleep breathing problems are central sleep apnea, similar to stochastic breathing, obstructive sleep apnea, and mixed pattern of both, and 44% experience restless sleep, and 41% had trouble falling asleep, 39% woke up early, and 32 had difficulty returning to sleep after waking up early or short. In addition, sleep disorder breathing as obstructed and central sleep apnea occur in 45 until 82% of patients with heart failure. And self-care in heart failure, self-care is either by heart failure patients to maintain their health and recognize the symptoms that appear. Effective self-care can be important factor influencing the improvement of health condition of heart failure patient. The process of self-care through health promotion practice and managing disease in patients with heart failure include three dimensions: self-care maintenance, self-care monitoring, and self-care management. And for the urgency, the deterring sleep quality affects physical health, cognitive performance, activity, and mental health. It also has been argued that sleep deprived people may not be able to exercise good and effective self-care. Today, the only available literature synthesis on sleep quality and self-care is older than 10 years and none is systematic. The further research and need to be able to have a systemic and relevant system of evidence to understand the relationship of sleep quality and sleep care behavior with heart failure patients. Next slide.
Miss Septi, I'm sorry, the time left is 3 minutes, so you may do it faster. Thank you. Mrs. Septi, I think you still mute your mic.
Okay. Can you repeat what you say? I must to move to the conclusion or I must continue my presentation?
Okay, the time left now is 2 minutes. So please, maybe you can read the discussion a little bit and then jump to the conclusion.
Okay. For the conclusion and the result of the current study also obtained uh, a very big coefficient value strong predict because the strong predictor of our failure self-care include family support, knowledge of self-care, and self-efficacy and medication adherence. And okay, and from the T-square, I do the T-square test, and the result is show the poor sleep quality has inadequacy of self-care as much 57 adequate and self-care as much 30.65 sleep quality is good with adequate self-care as much 22.85% and adequate self-care as much as 9.5%. And based on the T-square test results showing a 6 to 12 value 0.006 and hypothesis 0 rejected
Thus, there is a correlation between sleep quality and self-care in heart failure patients. The coefficients between the relationship and between the correlation between sleep quality and self-care in a heart failure patient. And so one sleep quality parity with adequate knowledge can lead to skills that are not managed properly by heart failure patient, coupled with a lack of confidence in the capacity to perform the skill. When lifestyle changes are not implemented properly, the result is often repeat hospitalization. There are therefore appropriate self-care intervention for
Mrs.
patients.
Epic.
And in addition to improving patient self-care can reduce the recurrent rate of heart failures. I think enough for my presentation. Thank you for your attention. And I give my screen and time to the moderator.
Okay, thank you,
Assalamualaikum
Miss.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the great presentation. Since we are running out of time, so we may move to the next presenter, which is Ms. Sri Rahayu, with the topic differences in informational needs between family caregivers of heart failure and stroke patient. For Ms. Sri Rahayu, time and screen is yours.
Yeah, thank you very much, Miss Adisti. Okay, I would like to share my presentation. Sorry. Wait for a second. Respon apa? Yes. Can you see my PPT or point?
Yes.
Yes. Okay. Yeah. I'm glad to be here to present my research topic. My research with the topic differences in informational needs between family caregivers of heart failure and stroke patients. These are the outline from first background until the conclusions. And for the background, caregivers here are important for a patient to fulfill the patient needs for 24 hours a day. And family caregiver are people who play a very important role in providing patient care at home and also providing support to patients. And the data show that around 90% of care is provided by family caregivers that related to the national caregivers organizations. And the last, why I concerned about these two kind of disease, because cardiovascular disease is the #1 killer disease in the world. The data in 2019 show that around 17.9 million suffer in these patients, include the patient stroke. And for the study purpose is to identify the differences in informational needs between family caregivers of heart failure and stroke patients. And these are the method. The research design I use here is a cross-sectional study, and the place of I conduct this research is in Jakarta. The hospital is SPAD Gatot Subroto, or we can call National Army Hospitals. This conduct in December 2019 to February 2020, so before the COVID-19. And the participants are 52 family caregiver of heart failure patients and also 52 family caregiver of stroke patients. And the questionnaire used is KICIC questionnaire, we call this. This family caregiver informational needs. This questionnaire I developed based on the theory and also the national caregivers organizations. So I developed this questionnaire for 20 questions and use a Likert scale Yeah, use the Likert scale from 0 to 4, not important to very important. And for the result of the validity is 0.97 and the Cronbach alpha is 0.89. And for the analyze the data, because this cardiovascular disease, this heart failure, and also the stroke patient, I use a pair t-test. And the results show that here we can see the mean of this informational between two family caregiver in different populations. The stroke patient are higher than the heart failure patients. And for the p-value is 0.017, so it's mean that there is differences in informational need of caregiver heart failure patients and also the stroke patients. In the conclusion, there are differences in the information need of family caregiver from heart failure patient and also the stroke patient. And here it is the references I use to support my research. And thank you. Maybe any questions?
Okay, thank you, Mrs. Rahayu, for the presentation.
Yeah,
For
you're
the
welcome,
particip-
Ms. Adisti.
Okay, for the participant who would like to ask the question, you can raise your hand. We still have 2 minutes left.
Okay, may I ask Mrs. Adisti?
Yes, please, Mrs. Dian Hawati.
Okay, I'm very interested about the research from the Mrs. Rahayu. May I would like to maybe asking or about the data analysis. You mentioned before that you use for the data analysis is per t-test, is right? Yes, okay. That for the questionnaire, for the validity, or for the question, research question for the your data.
Yeah. Okay, thank you very much, Ms. Dian, for your questions. I use a parity test for to identify the differences to groups. Actually, these are the same population in cardiovascular disease because, as we know, that cardiovascular disease is coronary heart disease, heart attack, heart failure, and also the cerebrovascular disease. So these are the same population. For the validity, I use what is person correlations and also the reliability use the Cronbach alpha. So it's different. There's a previous study for validity and reliability.
Okay, thank you. Me, I would like to confirmation. As I know, for the parity test is for the same group. I mean, just like a pre-test and post-test with the same sample like that, same participant. But for this is family caregiver in the heart failure and the stroke is different participant, right?
Yes, actually these are different population, but I put in the big population of the cardiovascular disease. I didn't move to others patient population. So the big population are cardiovascular disease. This related to the WHO and also the American Heart
Yes,
Association.
yes. No. What is I mean is about the data. The data of KK is from the two different sample like that. The first sample is from the group of heart failure, and the second group, the family caregiver from the stroke. So I'm sorry. From what I know, I think that right to use the independent t-test rather than per t-test like that. Okay, thank you.
Okay, thank you for your suggestion, Miss Dian. I will try to check again for this. Yeah, because my assumption before is the same population. Thank you very much.
Okay, thank you.
Okay, thank you, Mrs. Dian Hudi for the question and Mrs. Sri Rahayu for the answer. We move to the next presenter, which is Miss Rizky Anjarsari, with the topic, the correlation between anxiety and medication adherence in patients with heart failure. Miss Rizky Anjarsari, the time and screen is yours.
Profesi.
Oh,
Sorry, Miss. Wait a minute. Okay.
Miss Ridahayu, you may unshare or stop share the screen so another participant can share. Okay, yeah, thank you.
Yes. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, my name is Rizky Anjarsari, and I will presenting about correlation between anxiety and medication adherence in patient with heart failure. Next, please. Okay, so for the first is introduction. According to American Heart Association, congestive heart failure is a condition when the heart cannot pump enough blood to the organ so that the heart works harder, not as it should. Usually, the cause of heart failure comes from disorder of the pericardium, myocardium, endocardium. Some patients experience it due to weak left ventricular myocardial function. So in the right side, there is a prevalence of heart failure in the world, Indonesia, and province of Central Java. Based on data from the Global Health Data Exchange in 2020, the number of congestive heart failure cases in the world reached 64.34 million cases, while the result of basic health research data in 2018, the prevalence of heart disease in Indonesia it was 1.5% or around, sorry. And meanwhile, the Central Java Provincial Health Office has decreased the cumulative number of new cases of congestive heart failure from 2018 by 9.82% to 1.90%. Okay, so next. Okay, for the background, heart failure can affect the physical and psychological condition of the sufferer. One of the psychological conditions shown by people with heart failure is anxiety and depression. Research on patients with heart failure by Polychondriatic 2015 show a prevalence of high anxiety as much as 32.6%. Research by Hudiawati and Prakoso 2020 has proven the relationship between heart failure and depressive symptoms. Around 9% to 60% of heart failure patients experience depressions. Anxiety can affect a person's behavior. This is evidence in the result of Chiarong Wu research 2013. Previous result explained the reason why patients with depressive symptoms are more likely to be non-compliant with their treatment regimen. This is due to greater feelings of hopeless social isolation, withdrawal from social networks, and decreased cognitive function. And research by Akilopoulos et al. 2017 proves that depression can worsen heart failure treatment. Okay, next.
From research methods, this study used quantitative methods with a correlation descriptive approach. The population of this study was heart failure patient at the outpatient polyclinic of ONS hospital, and the sampling technique used purposive sampling with a total sample of 103 respondents, and the instrument that I've used is cardiac anxiety questionnaire and Morisky motivation adherence questionnaire. Okay, so for the result and discussion on the top table 1, characteristic of respondent, based on the result of research on the characteristic of respondent, the majority of heart failure suffers age 66 until 75 years. The result of the analysis of respondent characteristic by sex show that the male sex dominated heart failure. Meanwhile, based on the last education, the majority of heart failure patients attended elementary schools. For the distribution of respondent characteristic based on the length of suffering from heart failure, the majority of respondents suffered in the range of 1 until 2 years. And the study found that there were more respondents with NIHA 2 categories than 3 and 4 degree categories. Okay, next, the table 2, distribution of anxiety and medication adherent respondent. We can watch the table 2 describing the distribution of respondent anxiety frequency. Respondent who had low anxiety were 81 people, or 78.6%. Moderate anxiety levels were 8 people, or 7.8%, and high anxiety levels were 14 people, or 13.6%. In addition, in the table 2, explaining the frequency distribution of treatment adherence, respondents show that the majority had moderate adherence, 38 people, or 35.9%, low adherence, 17 people, or 60.5%, and high adherence, 48 people, or 46.6%. Okay, still on the result and discussion, table 3, correlation of anxiety and medication adherence in heart failure patients in hospital. We can see that table 3 show respondent who had low anxiety with low medication adherence as many as 0 people, or 0.0%, moderate medication adherence as many as 4 people, or 3.9%, and high medication adherence as many as 4 people, or 3.9%. And in respondent who had moderate anxiety with low medication adherence as many as 15 people, or 14.6%, and moderate medication adherence as many as 29 people, or 28.2%, and high medication adherence as many as 37 people, or 35.9%. While respondent who had high anxiety with low medication adherence as many as 2 people, or 1.9%, moderate medication adherence as many as 5 people, or 4.9%, and high medication adherence as many as 7 people, or 6.8%. So based on the result of this,
the time left
yes.
is less than 1 minute, so you may do it quickly or jump into conclusion. Thank you.
Oh, okay. Sorry, Miss. Okay, so for the conclusion, based on the result of statistical analysis, it can be concluded that there is a significant relationship between anxiety and medication adherence in patients with heart failure. Because before that, on the table 3, we can say that p-value 0.05. So the age null is sorry. So age null is rejected so that there is a relationship between anxiety and medication adherence in patients with heart failure. From the results of this study also found that anxiety factors are not the only factor that affects medication adherence for heart failure patients.
Okay, the
Okay,
time
thank you.
is okay, yeah. Thank you, Ms. Rizky, for the great presentation. I'm sorry because we are running out of time, so we may move to the next presenter, which is Mrs. Nobrila Salsa Oktandora. Okay, the time and screen is yours.
Okay, can you see my PPT?
Yes, of course.
Okay. Assalamualaikum warahmatullahi wabarakatuh. It is an honor to me to be a present at Ichwb today. I'm Nobril Salsa Oktandora. As the first author of this article, we present some explanation about my research. The title is The Relationship Between the Self-Efficacy and Physical Activity in Patients with Coronary Heart Disease. Okay, one of the most common cardiovascular disease in Indonesia is coronary heart disease or CHD. Based on data from Basic Health Research, the prevalence of heart disease in Central Java is 91.161. And according to the World Heart Organization 2020, CHD ranked first among of the 10 diseases that caused death between 2000 and 2019. The number continued to increase, reaching 8.9 million deaths in 2019. Many factors increase the risk of cardiovascular disease such as hypertension, hyperlipidemia, smoking, physical inactivity, obesity, and unhealthy diet. These poor lifestyle habits are the reason why patients are less motivated to implement healthy lifestyle habits. Unmotivated people feel unable to achieve the desired result, or what can be called low self-efficacy. Self-efficacy is the belief that a person is capable of performing certain behavior to achieve certain results. Patients with low confidence in their ability to perform recommended behavior tend to have low self-efficacy and affect physical activity. Patients with GHD problems are generally advised to engage in regular physical activity at least 150 minutes per week and to reduce the intensity of sitting time. However, in reality, it's not unexpected. Previous research by Nikadek 2023 found that 41.3% of people with GHD do not do any moving activity. Therefore, it is necessary to increase self-efficacy in patient and family to increase complaints in the implementation of physical activity so that treatment can take place optimally. Okay, for this method, this study used a non-experimental research design of analytical cross-sectional type using purpose sampling data collection technique conducted in August to October 2023 among outpatients at the Heart Clinic of Muardi Hospital, Surakarta. Samples were taken as 97 respondents and selected according to the inclusion and exclusion criteria. And the instrument used is cardiac self-efficacy or TSE and rapid assessment of physical activity. Okay, for the characteristic respondent from the demographic table data of the respondent above, it is stated that GHD patients are dominated at the age of 15 years. It's 39.2%. Because at the age of more than 45 years, the state of amyloid accumulation, basophilic degeneration, lipofuscin accumulation, thickening, and stiffness of blood vessel and increased fibrosis is change. Meliani 2023. For then, gender is dominated by men, 68% because men do not have the hormone estrogen as protection against blood vessel elasticity. Coupled with lifestyles such as smoking and alcohol consumption, which are dominated by men compared to women. Tampu Bulan 2023. And the majority of respondents is work, 74.2%. And individuals who have a job will pay less attention and take less responsibility to their health because they are focused and busy at work. So they will tend to have lower self-efficacy. And then the majority of respondents' last education was senior high school is 36.1%. Individuals with high level of education will have extensive knowledge compared to individuals with low level of education. Then the majority of respondents suffered from GSD less than 1 year. It's 54.6%. Individuals who have been suffering from their disease for a longer period of time will have more experience in dealing with various problems and will be able to solve them independently. This is consistent with the result Rokhayati 20 and 20, research that the longer an individual suffers from GSD, the higher the self-efficacy. Okay, for the self-efficacy, it was found that the majority of self-efficacy in GSD patient at Muardi Surakarta Hospital was low. Is 51 respondent or 52.6%. It can be seen that respondents have low self-efficacy more than those with high self-efficacy. Increasing self-efficacy is inseparable from the process of mindset, high motivations, effective pattern, and choice. The mindset process can influence patient motivation, which can be helpful in patient care. Self-efficacy can also have an impact on self-management. Poor self-management will also affect its survival. Ekawati Rahayu 2022. Self-management, which has an impact on self-efficacy, is initially based on knowledge in ignorance of what needs to be done about their health status will have an impact on the ability to believe in their actions. Putri Hudiawati 20 and 22. Apart from knowledge, external things that improve self-efficacy are support from various things, especially its family support. Sundari 20 and 23. Okay, for physical activity. For the physical activity shows that most GSD patients at Muardi Hospital have less than optimal physical activity. It is 75 respondents or 77.3%. This is consistent with Becker Research 2021, which found that patients with GSD tend to have suboptimal level of physical activity. Physical activity can be considered optimal when individual can do it regularly and in a structured way according to exciting guidelines. Optimally performed physical activity can help open the ventricle to make it large, allowing the heart to pump more blood. In patients with GSD, at least 150 minutes of physical activity per week. Amroseti 20 and 21. Of moderate intensity divided into 2 sessions has been shown to stimulate the sympathetic nervous system and will induce an integrated response where its response can maintain an appropriate level of homeostasis in increasing physical, metabolic, respiratory, and cardiovascular effort. Okay, for the correlation, it's
the time
Yeah.
left is 1 minute, so you may do it quickly. Thank you.
Okay. Okay, jump into conclusion. So from the result of this study, it can be concluded that there is a relationship between self-efficacy on physical activity in patients with coronary heart disease, and the strength of the relationship is moderate. The majority of coronary heart disease in patients in Muardi Surakarta Regional General Hospital have low self-efficacy, so it can affect suboptimal physical activity. That's all my presentation of me. Please apologize if there is a mistake. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you for the presentation. I'm sorry because time is running out, so we may move to the next presentation. There will be Mrs. Cecilia Hani Oktavira with the topic relationship between physical activity and sleep quality in heart failure patients. For Miss Cecilia, the time and screen is yours.
Okay, thank you for Mrs. Adisti. Let me introduce myself. My name is Cecilia Hani Oktavira. I'm from the Faculty of Health Science Nursing Study Program, Muhammadiyah University of Surakarta. Here I will present the result of my research entitled The Relationship Between Physical Activity and Sleep Quality in Patients with Heart Failure. Okay, now let's start from introduction. Prevalence of heart failure. First, according to WHO in 2021, found 41 million deaths worldwide caused by non-communicable disease, and heart disease will contribute 43.6% with 17.9 million deaths. Ministry of Health, Republic of Indonesia. Then from Global Data Exchange in 2020 shows the number of cases of heart failure worldwide will it reach 64.34 million and 9.91 million deaths. Lippi et al. 2020. And from Basic Health Research in 2018 found 15 of out 1,000 or around 4.2 million people in Indonesia suffer from heart disease. Discussed as 2018. Next, common symptoms of heart failure are pain, dyspnea, edema, persistent coughing or wheezing, fatigue, increased heart rate, and sleep disorders. Sleep disorders are found in almost 75% of heart failure patients, which greatly affects sleep quality. Patients with heart failure often have poor sleep quality, Spectral et al. 2020. In heart failure patients, physical activity is one of the simplest and possibly cheapest strategies or therapies to carry out. Regular physical activity can improve sleep quality, but research by O'Donnell et al. 2020 shows that the physical activity of heart failure patients is an average of 16% lower. Lack of knowledge about self-care causes heart failure patients not to realize the importance of physical activity. Knowledge about self-care, one of them is physical activity, is very important for heart failure patients because it is a supporting factor and affects the treatment process and improves quality of life. Next, for method, this type of research is a quantitative study using an analytical cross-sectional approach in heart failure patients at the heart clinic at Dr. Morty Regional General Hospital. And the study lasts from August to November 2023. For the sample, that was 102 respondents taken using purposive sampling. The data collection tool used was a questionnaire consisting of the rapid assessment of physical activity and the Pittsburgh Sleep Quality Index. The data that has been collected is then processed using SPSS, carrying out univariate tests and bivariate tests using the Spearman test. Next, for the result, table 1 illustrates that 102 respondents with heart failure, majority of were aged 56 to 65 years, with 35 respondents, and 34.3%. And majority of respondents are male, with 79 respondents, 77.5%. The last education taken by respondents was mostly elementary school, with 45 respondents, 40.2%. Respondents who worked was 80.4%. The length of time suffering from heart failure for respondent less than 1 year amount to 40 respondents, while more than or equal to 1 year, as many as 62 respondents. The majority of respondents who participated in this study didn't have comorbid disease, with 78 respondents, 76.5%. And the most New York Heart Association classification was in 2, which amount to 50 respondents, 49%. From result, physical activity and sleep quality in heart failure patient in this table, the study showed the majority of respondents had suboptimal physical activity. Physical activity is an important part of primary prevention in heart failure patients. Regular physical activity is also a key way to maintain health and treat disease. Lamonte and Eaton, 2021. However, physical activity can decrease with age. The majority of respondents are in the elderly age category, which causes their physical activity to be less than optimal. Klomstra et al. 2022. The result of the frequency distribution of sleep quality showed that the majority of respondents has good sleep quality. This contradicts the research of Spedal et al. 2020, which states the heart failure patients often have poor sleep quality. Many factors affect the sleep quality, not only from disease symptoms. Some other factors that affect sleep quality in heart failure patients are age, education level, uncomfortable living space, and perception of disease prognosis. At Milam et al. 2020. Not all patients with heart failure have this problem, so that not at all patients with heart failure have poor sleep quality. Next, from discussion, the result of the analysis show that there is a relationship between physical activity and sleep quality in heart failure, and a negative correlation. This show a significant and inversely proportional relationship. The higher sleep quality score indicates poor sleep quality, while the higher physical activity score indicates optimal physical activity, which means that increased physical activity improves the sleep quality of heart failure patients. This is in line with research Spedal et al. 2020. The result of the analysis show that more optimal physical activity, the better the quality of sleep. Based on the closeness of the relationship between physical activity and sleep quality, it is included in the weak category. This is because sleep quality is not only influenced by
I'm sorry.
physical.
The time left is less than 1 minute, so you may jump into the conclusion. Thank you.
Okay, jump to conclusion. Based on research conducted on heart failure patient at Dr. Muardi Surakarta Hospital, it can be concluded that there is a relationship between physical activity and sleep quality in heart failure patients. The majority of respondents have good sleep quality with less than optimal physical activity. From the result of the study, it was also found that physical activity did not have a strong effect on sleep quality. Many other factors can affect the sleep quality of heart failure patients. Okay, thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, right on time, Mrs. Cecilia. Thank you for the great presentation. Okay, so for the last session in this room or in this presentation, there will be an announcement of the best presenter for today. Who will be the best presenter? Does anyone know? Can anyone guess who's the best presenter in this room? Okay, I think no one has a clue. So yeah, the best presenter for this room or for today's presentation is Mrs. Maslinda Musa. Yay, give an applause to Mrs. Maslinda. Is she still here, Mrs. Maslinda? Hello. Oh, I think she has left the room. Yeah. Okay, and that's all for today's presentation. Yeah, I think that's enough for me. And I, Adisti, as moderator, as for leaving. And I apologize if there are any speaking or behavioral errors during the presentation. And all the participants are can leave the meeting without returning to the main room. So thank you for your attention and see you on the next next time or next opportunity. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam
warahmatullahi
warahmatullahi wabarakatuh.
wabarakatuh. Thank you, Miss.
You're welcome. You're welcome.
Terima kasih Bu Adisti.
Sami-sami, Mbak. Ini sudah ya, Bu? Izin live?